Welcome to all participants on behalf of the IAS Education Fund and MOJU to the second session of the symposium. I am Julian Etima, and I'll be chairing this session, which will focus on innovative prevention methods in Uganda and East Africa. We have a very interesting lineup of speakers for this session who will be communicating on this topic and will participate in a question and answer session during which you, the participants, will have the opportunity to ask questions to our panelists. We sincerely hope that this programming will be of value to you all for your current work. I would like to share a few housekeeping rules. All participants are muted. I invite all those connected virtually to please introduce yourselves by typing in the chat or the interactive box that is right underneath the screen. And you will see the message shows in the interactive box to the right of the screen. Please type your first name, last name, the organization you work for, and the country you are from. Let's use this opportunity to connect and get to know each other. If you are having technical issues and are unable to see the chat box, I would like to invite you to change your internet browser. Please use the same chat box during the questions and answers time that will take place right after the presentations. You are also welcome to send comments in the chat box. As an active participant of the IAS Education Fund Uganda and East Africa Symposium, you have the opportunity to receive a one-year IAS membership at no cost to you. The membership will be activated once you fill in the post-symposium survey and tick a box in the survey requesting this membership. If you are already an IAS member, the existing membership will be extended by 1 year. All participants of this meeting will receive an email requesting that you please participate in our survey to evaluate this symposium. You will have the opportunity to let the IAS team know if you would like to become a member then. Now I am pleased to introduce our first speaker for this session. Dr. Clemencia Nakavito is the CRS leader, clinical research site leader at MOJU Care Limited and MOJU Research Collaboration in Uganda. Dr. Clemencia Nakavito will present the overview on innovative prevention methods, including PrEP, the pivirine rings, islatravir, and MPT rings. Dr. Nakavito, the floor is yours.
First of all, I would like to thank the organizers for having given me an opportunity to present at this symposium. And my topic is the overview on innovative HIV prevention methods. This is a snapshot to show the HIV prevention research, development, and implementation pipeline in 2021 and beyond. So we have on my left the currently available methods, which include HIV treatment for people living with HIV, male and female condoms, voluntary medical circumcision, and daily oral PrEP. There are pending products which are under regulatory review. We have completed the research, and these are the pivirine ring, vaginal ring, and the long-acting injectable cabotegravir. There are also other products which are in development, have been in development, but they are undergoing efficacy trials. And these are long-acting. There is a long-acting injectable preventive vaccine, daily and monthly oral PrEP, and a combination of PrEP and oral contraceptives. There are also other products we are still far in the development. They are still in the preclinical trials in animals. Others are already in humans, but in the early phases. We have long-acting implants, preventive vaccines, multipurpose vaginal rings, broad neutralizing antibodies, inserts, patches, long-acting vaginal ring, and the enema. So there are plenty of products which are being done on research. Others are waiting for approval. We have a dapivirine vaginal ring. This is a flexible silicone vaginal ring developed by the International Partnership for Microbicide, a non-profit group. Can you cut? One of the long-acting PrEP product is a dapivirine vaginal ring. The vaginal ring is a flexible silicone ring which is developed by the International Partnership for Microbicides, IPM. It is intended to be used for a month at a time, and women can insert it and remove the ring themselves. It slowly releases the ARV drugs, which is called dapivirine, and there are 2 phase 3 trials which have been conducted, and this Aspire study and the ring study. And these were conducted in parallel to enable rapid regulatory submission if the ring is found safe and effective. The dapivirine ring, more studies were done in other populations which had not been included, like adolescents, pregnant women, and breastfeeding women. And these results for the adolescent, the results are expected in 2022, and that each time they were comparing the dapivirine ring and the Truvada, they were not placebos. So some groups were in the ring, others were using the Truvada. The safety of the dapivirine ring and oral PrEP in pregnant women has been studied, but it is continuing because the groups have been put in 4 phases, starting with the pregnancies which are advanced, where we expect minimal complications. For the breastfeeding, the study has been completed, and we expect the results in early 2022. So at the end of this, if we find that the ring is safe and tolerable in all groups, it will be that all the women, different cycles are covered of the lifespan. Now, what about access? The timeline is in progress for access to the dapivirine ring, and we find that IMA, already I told you, gave it a positive opinion, and also WHO recommended the ring to be an additional prevention for women at substantial risk of HIV, and the WHO also added it in their clinical guidelines for ARV drugs for HIV prevention. The PEPFAR as well also has included it in the guidelines for 2021. As at a country level, Zimbabwe has already, the regulatory body of Zimbabwe has approved the use of the ring. But of course, they haven't started using it. Our countries in Kenya, Malawi, Rwanda, South Africa, Tanzania, Zambia, and Uganda, the processes are going on, and I think Uganda has reached an advanced stage, and they will soon announce that they recommend, they approve the ring for use once we have all the regulatory approvals. We anticipate that in December this year, the U.S. Food and Drug Administration will make a decision on the dapivirine ring application. Application has been logged by IPM. What about the injections? Injections, we have the long-acting injections. We have so far cabotegravir, which is being developed for both HIV treatment and prevention. This one supports 2-monthly dosing, and we have completed, the studies are still going on, but we already have had the results, and which I am going to inform you later on. There is also another injection called lenacapavir, which supports 60 monthly dosing. So you get an injection once a month, once in 6 months. Whereas cabotegravir, you get an injection once in 2 months. So the study for effectiveness and safety for this 6 monthly dosing is underway. Now for the cabotegravir injection as PrEP, the study found, so far the study is still going on, but so far was found that to be safe and effective for women aged between 18 and 45. And also in Uganda, 3 sites participated in Muju, Beira, and Ayavi in Entebbe. So far the cabotegravir is also going under that rigorous regulatory review until we get approval of recommendation to use the injection. Of course, there are studies which are being designed to find that maybe we can, in adolescents, pregnant women, breastfeeding women, as we had done for the pivoting ring, so that the different populations are covered. Now we have also another long-acting but oral drug which is called islatravir, which is being developed for PrEP. It is a monthly pill developed by Merck, Sharp, and Dohme. It is a unique, highly potent long-acting antiretroviral, and the phase 3 trial is being conducted in the US and 21 African countries among women aged between 16 and 40 years. Uganda is also going to participate in this study. Other South African countries have started, but soon Uganda will be approved to start because we have many other things in the preparation we have to satisfy. But it will soon be open to Uganda. So this islatravir for PrEP is once a monthly pill, is once a month, which means in a year for one who is on PrEP will only take 12 pills. Now what do we have? Because as I told you, Truvada is the only pill which has been approved for PrEP use, for use in PrEP, in prevention. The other products are being developed. Now, we expect on the market in future, if everything goes well, the researches which are being conducted, the regulatory reviews which are being conducted, we anticipate that in the prevention product, the basket will have a vaginal ring, the pivoting ring. By maybe 2024, it will be on the market. The long-acting injectable, cabotegravir and the lenacapavir, 6 monthly, cabotegravir 2 monthly will be. It is possible that by 2024 we'll have these products approved for use. We have a dual prevention pill which contains Truvada combined with oral contraceptives. We expect that if researches go on well and we find safety and efficacy, we may find it possible to have this approved early in 2024 or late in 2024. Another product we expect is, of course, the oral PrEP, the long-acting oral PrEP, islatravir. There is also another oral prep, which can be combined with the, instead of tenofovir, it is called TAF. It can be combined with the emicitabine, and this one is a daily one. But for islatravir, as I told you, it is a monthly pill, and we expect that maybe somewhere before 2024 it will be on the market. Preventive vaccines are also, studies are being conducted, and they have started with the men having sex with men and transgender people. Of course, when they find that in that population maybe these products are safe, they can be moved into our populations, which are not gender, cisgender, whatever, transgender population, and we have vaccines on the market. For that one, I don't know how far we are to go, but there is hope that we have a number of products, and many of them long-acting. Why are we struggling to have all these products? It's because HIV prevention cannot be one size fits all. Choice matters. We want on the market in the future to have choices, so that one can choose a pill, can choose from, and the pills can be, you can choose from a Truvada, from TAF, from islatravir, which is a monthly pill, only take a 12. You can choose a daily pill depending on what you want. The vaginal ring can be one of the choices, and there will be other rings which will be developed from other antiretroviral drugs. We can choose injectable. Injectable, we have a 2-monthly, we hope we shall have the 2-monthly injection approved, the cabotegravir. And then the lenacapavir, which is going to start to be researched on, which is only given once every 6 months. And we also have other vaginal inserts which are being developed depending on what one wants. You can choose from many products. There are also other implantable products which are being researched, and I think we shall keep you updated as we move on. But of course the journey is long. But one time, I think we are going to achieve a basket full of many products, so that one can only choose what they want. So what are our final thoughts? More safe and effective HIV prevention options are entering the market and in development. The PrEP pipeline is rich and promising. No one method will be the right option for everyone. Development and testing of new biomedical interventions is necessary and will continue. We need appropriately tailored interventions that can consider real-world practices and individual needs and wants. So, in summary, I have these products: the ring, the injectables, the tablets, which may be different tablets, and all the colors you are seeing. I think we shall achieve that. I think all this has been not without efforts of everybody. It has been everyone's efforts and dreams. Before I end, I would like to appreciate everybody who helped me to give me information, some of the information. Those who gave me the slides, some of the slides I borrowed them from other people. I would like also to thank the donors, the funders, all the scientists, all the researchers who have helped this timeline, development and developments in the pipelines. I would like, last but not least, our dear participants who have been with us in this struggle and have really participated in the studies at any one time, being inconvenienced, risking being researched on products which have found our, it's not a straight path, but they have really contributed tremendously. Thank you so much. And thank you for listening to me, everybody here.
Thank you, Dr. Clemencia, for this very interesting presentation. I am now pleased to introduce Andrew Mujugira, who works in the Infectious Diseases Institute, Kasangati, at the Makerere University in Uganda. He will be presenting on PrEP in Uganda. Andrew, the floor is yours.
Hello and welcome to this talk on PrEP in Uganda. I am Andrew Mujugira, clinical epidemiologist at Makerere University Infectious Diseases Institute. I have been involved in PrEP research since 2008, starting with phase 3 efficacy trials and then demonstration projects. And I'm now involved in implementation studies for various key populations. Uganda has made significant strides in reducing HIV incidence. In the decade between 2010 and 2020, the number of new HIV infections in the country declined from 94,000 to an estimated 38,000, a 60% decline. Similarly, we saw reductions in HIV incidence among young people aged 15 to 24 from an estimated 29,000 infections in 2010 to 14,000 in 2020, representing a 53% decline in HIV incidence. However, it is concerning that 37% of all new HIV infections in the country occur among young people. And this burden is disproportionately borne by adolescent girls and young women, who account for 29% of all new HIV infections in the country, despite representing 10% of the population. This burden is likely to increase because of COVID-19 pandemic lockdowns. Schools have been closed for about a year and a half, and we know that keeping girls in school is protective against HIV. We have seen anecdotal reports of increases in teen pregnancies during the lockdowns, as well as data that was presented at the International AIDS conference in July, which showed increase in sexual assault during the lockdown periods. So our progress in reducing HIV incidence in this population may be undermined by COVID. PrEP was approved in Uganda 5 years ago and is available as an oral tablet, either lamivudine with tenofovir or emtricitabine with tenofovir. Studies of a new PrEP drug called TAF, tenofovir alafenamide. This is a drug that was approved by the US Food and Drug Administration in October of 2019, and is being used in the United States and Europe. We are currently doing a study of TAF as PrEP at the Infectious Diseases Institute, and this is one of the first studies of TAF in sub-Saharan Africa. In Uganda, PrEP is recommended for key and priority populations at risk of HIV, and is delivered through a combination of facility-based and community-based models, including drop-in centers, community drug distribution points through peers, and community pharmacies. We have conducted over 20 PrEP studies in Uganda over the past decade and a half, majorly at the Infectious Diseases Institute, but also at other key research institutions in Uganda, majorly MUJU and the Medical Research Council UVRI partnership. As we know, in Uganda, starting PrEP involves a first visit where HIV testing is done, and behavioral risk reduction counseling is also performed. And initiates are given a 1-month supply and has to return after a month for additional evaluation, following which they take PrEP quarterly. In 2020, Uganda aimed to reach about 222,000 members of key populations for PrEP. Of these, 170,000 were tested for HIV, most of whom tested HIV negative. 95,000 of the 164,000 were screened for PrEP, and of these, 63,000 were found to be eligible for PrEP, and 46,000 started on PrEP. You can see from this cascade that only about 1 in 4 of those who tested HIV negative started on PrEP, representing a significant leakage in our PrEP cascade. Even of those eligible, not everybody started PrEP, and we could do better to optimize PrEP delivery for those who need it. These data from the National PrEP Program over the past 5 years show the number of key and priority populations taking PrEP. On the left-hand side of the screen, you can see the populations disaggregated, and the blue bars represent the numbers who started PrEP cumulatively over the past 5 years, and the red bars show the cumulative number of people who came back for refills after initially starting PrEP. With the x-axis starting at 75%, what strikes you is that less than 10% of most of these populations returned for refills. The only population that stands out was people who inject drugs, of whom about 17% came back for refills. The bottom 2 bars represent populations added to the National PrEP Program, and so we don't yet have refill data for border riders and adolescent girls and young women. Overall, the picture is that of people initiate but don't continue. Reasons for this are varied. A root cause analysis of the National PrEP Program suggests that there are a myriad of factors that reduce PrEP persistence, one of which is HIV stigma. We use the same drugs for treatment and prevention, and they're dispensed in exactly the same bottles and mostly in exactly the same clinics. And so when somebody is taking PrEP and they're discovered with the bottle, they're assumed to be taking ART. And HIV stigma discourages people from taking, particularly if they are in relationships and do not want the other person to know they're taking PrEP. Other factors include transport challenges, forgetting, high mobility, and a fear of side effects. This performance of our National PrEP Program suggests that we need to do a better job of optimizing PrEP delivery for people who need it. And we're doing this by differentiating PrEP delivery, which means we are taking PrEP out of the medical facilities and into the communities where the people who need it are. We are task shifting away from doctors and nurses and empowering community health workers and peers to deliver PrEP to those who need it in their populations. We are also distributing HIV self-test kits, which obviate the need to come into clinic for testing, and that people can test themselves in private and find the results themselves. We're increasing access points through drop-in centers for key populations, community drug distribution points, and community pharmacies, as well as empowering PrEP champions, people who are users of PrEP, who are members of key populations who have who can communicate effectively and are known by these populations about side effects, adherence, risk reduction, and seasons of risk, to share the message that PrEP is not a lifelong intervention. It is for seasons of risk. We continue to battle stigma, especially among key populations, and we need to normalize people starting and stopping PrEP, that it's okay to cycle out if you no longer need it, and cycle back in if you think that you're at risk. And importantly, we are expanding the method mix by providing choice of a tablet, a ring, and soon an injectable, so people can use whatever PrEP method works best for them. All this to say we're individualizing HIV PrEP delivery because one size does not fit all. For some, a daily pill with either TDF or TAF may be preferable. For others, it may be a monthly vaginal ring with dopivirine, which was recently approved for use in Uganda and is under regulatory review in other African countries. And for others, it may be a 2-monthly injectable with cabotegravir, recently found to be highly effective at preventing HIV and is under regulatory review by regulators around the world. This method mix should expand choice and ensure that people can use the method that works best for them. The exciting products in the PrEP pipeline, including on the oral PrEP side, a monthly pill called islatravir, currently being evaluated in the Empower 022 and 024 trials in Uganda and elsewhere. And this reduces the pill burden from 365 to 12. The vaginal PrEP, the dopivirine ring is being approved or considered for approval across sub-Saharan Africa, and will be a convenient choice for those who choose to use a ring. Injectable PrEP products are also in the regulatory pipeline, either an intramuscular injection of cabotegravir every 2 months, or lenacapavir, which is a drug that is being evaluated and can be injected every 6 months and can be administered twice a year, adding additional convenience for those who would choose to use this method. In preclinical studies are a couple of implants, including islatravir, and this can be dosed once a year and will add even more breadth to our method mix. And so people can choose from a daily intervention to an annual intervention with all the options in between, further expanding the method mix for PrEP as we have done for contraception. So in summary, we have an effective self-control prevention tool that effectively prevents HIV, but persistence on this drug is poor, this intervention. And we need to optimize delivery by taking PrEP into the communities where people are, and by using innovative methods to make sure that people stay on PrEP, and that would not make it too difficult for people who want to start PrEP to do so. We are doing this re-individualizing HIV prevention. We're expanding our method mix. We're offering choice. And this hopefully will add an implant, a long-acting implant, to the available tablets, rings, and soon injectables. I thank you for your attention, and I look forward to the discussion. Thank you for listening.
Thank you very much, Dr. Andrew Mujigira, for this interesting presentation. I am now pleased to introduce Professor Kenneth Ngure, who is an Associate Professor of Global Health and Chair of the Department of Community Health at the Jomo Kenyatta University of Agriculture and Technology in Kenya. He is also a Governing Council member from Africa for the International AIDS Society. Professor Ngure will be presenting on PrEP in Kenya. The floor is yours, Professor Ngure.
Greetings. My name is Kenneth Ngure from Jomo Kenyatta University, and I'll be giving a brief talk on current status of PrEP in Kenya. So to begin with, is that we have a HIV problem in Kenya, like the rest of sub-Saharan Africa, and we currently have about 1.3 million adults living with HIV and about 139,000 children living with HIV, bringing to a total of close to 1.5 million. And we get about 36,000 new infections in a year. Therefore, HIV prevention is key. And as a way of background, and I know many of you have seen these studies over the last many years, is that we have been able to conduct several clinical trials that demonstrated that PrEP is a potent HIV prevention tool. And these studies were many that conducted from around 2007 to around 2012. And all these studies generated very solid evidence of safety and efficacy. And more specifically, what we have learned is that PrEP works when taken, and the higher the adherence, the better the efficacy, as has been demonstrated by these 3 studies and other studies, including the studies that did not show efficacy. We're able to look back and see that the real issue was that the people who enrolled in those studies were not adherent. So now coming more specifically to the PrEP status in Kenya, I'll take a step back and tell you that it has been a journey to reach where we are as a country. And the journey began in 2016, although around 2015, the WHO issued guidelines on PrEP. But then as a country, we launched new guidelines, ARV guidelines in 2016, and these were both for treatment and prevention. And that is where PrEP was mentioned for the first time. And soon after that, a couple of months later, we had the formation of the PrEP Technical Working Group by the NASCOP. And after that, there were a series of activities, and PrEP Technical Working Group is still there till today and guides the implementation process. And there were many activities that led to the National PrEP Scale-Up Launch, which happened in May 2017. And this launch was very colorful, as you can see, and was attended by high-profile people and implementers, including the Ministry of Health leaders or policymakers. And also, importantly, it was also attended by the media, which was able to both print and the rest of the media that was able to share this news to the rest of the population, which is important. When you launch something, people see it, they know that it exists, and that leads to better uptake. And also want to say that PrEP in Kenya is not a standalone program. It's aligned to the HIV prevention framework and is an additional tool to the other existing options that have always existed, and PrEP is then integrated into those other existing tools. The recommended drugs or ARVs for PrEP in Kenya are these 3, that is TDF, FTC, TDF by itself, or TDF 3TC, and I'm sure most of the people in the audience are familiar with these drugs. But who is eligible for PrEP in Kenya? PrEP in Kenya is given to people who are living with a HIV-infected partner who is not virally suppressed, and then for those who have a partner of unknown status and feel at risk of HIV, and again, those who engage in sex work, like sex workers, and then individuals with recent history of STIs. And I'm sure anytime as a provider, for those who are providers in the audience, anytime you see somebody with an STI is a marker of risk, and they could also be at risk of HIV. And then also clients who have reported recurrent use of PrEP. So every other time they go for PrEP, again, those are actually candidates who are cancelled for PrEP. And then history of using, having sex under influence of alcohol or drugs, or inconsistent condom use, or injection drug use. So who is taking PrEP in Kenya? This is a very important slide. And I can say that although I would want to first of all mention that we are reporting about those who had initiated PrEP up to June, who are 113,000. And as you can see, the distribution of people with the general population having the largest share of the people who have initiated PrEP. But I checked the numbers today, and I was told that currently in Kenya, we have initiated over 130,000 people. Again, they follow the same distribution. The other question that we may want to have is that during this time of COVID, how has PrEP initiation been? And I'm happy to report that even during COVID, that clinics have been very innovative, and we have been able to see uptake of PrEP across all populations. And you can see the numbers, that it was fairly consistent from January to June this year across all populations. Again, this is just showing how PrEP is taken and the people who take, and you can see the largest 3 populations: the general population, those in serodiscordant relationships, and the female sex workers. This table is again showing that information in detail. Here showing the numbers who have ever initiated, showing by population, and also, because this is a question that has been around for some time, showing the data between January to March, when the country was hit by COVID quite a lot, and April to June. And we also had looked at data in 2020 to show that the numbers were fairly consistent, but credit goes to the clinics and other teams for being very creative. And the part of the PrEP rollout in Kenya to get to these numbers is that there have been a lot of materials, educational materials developed, such as this, which have educated the population. But I also want to mention that the Ministry of Health, or NASCOP, does not initiate PrEP alone. It works with supportive partners who are listed here, and there are many others who are not in this slide. And one of them is the Giride project, which is a bridge to scale project, which had initially targeted around 20,000 people on PrEP, but ended up putting close to 40,000 people on PrEP, and PrEP was delivered in drop-in centers, public health facilities, private health facilities, and thereby exceeded the target. Another project which I'm well informed and well involved with is the Partner Scale Up project, which was delivering PrEP and ART to HIV serodiscordant couples and using PrEP as a bridge to ART, or PrEP as a bridge to virus suppression. And PrEP was delivered in public health clinics, but most importantly, the take-home message from this is that PrEP was delivered by staff already working in these clinics. And this is very important for sustainability, because when you work with staff who are already in these facilities, then it is possible that once the project ends, the implementation continues. And demand creation was through use of IEC materials, radio talk show, health talks in HIV clinics, and discordant couple support group. And this ended up putting close to over 8,000 people on PrEP, and most of these were in serodiscordant relationships. So as I come to the end, I would want to acknowledge the people who have been very bold, the over 130 PrEP initiators, the Ministry of Health and county governments in Kenya, including the technical working groups and NASCOP, the projects that I have mentioned that have worked together with Ministry of Health to initiate PrEP, the funders who have especially funded the projects, including NIH and Gates Foundation and Gilead Sciences for donation of drugs, especially for the initial trials. So thank you very much. I look forward to interacting with you all. Thank you.
Thank you, Professor Ngure, for this very interesting presentation. I am pleased to introduce Dr. Angela Langat, who is the coordinator of Beyond Zero Initiative, Kenya. She'll be presenting on the Beyond Zero Initiative, accessing healthcare and prevention in hard-to-reach areas, and making use of mobile clinics. Dr. Angela Langat, the floor is yours.
Hello and good afternoon. My name is Angela Langat, and I'm here to share with you the learnings of the Beyond Zero mobile clinics in delivering HIV prevention services and treatments in hard-to-reach areas. I'll switch off my camera to maintain a good bandwidth on my end. So the Beyond Zero initiative is an initiative of Her Excellency Margaret Kenyatta, the First Lady of the Republic of Kenya. It was conceived in June 2013 when the First Lady made a public commitment to heighten advocacy efforts aimed at reducing preventable deaths for mothers and children, as well as eliminate mother-to-child transmission of HIV and syphilis. In the following year, 2014, the Beyond Zero campaign was launched. It had an ambitious mission to give every pregnant woman and her unborn child the hope of living and saving children from HIV infection. It had a clarion call of no woman should die while giving life. And the core to our ideology is embodied by the 4 principles outlined there: complementing government efforts, being catalytic in nature, inspiring action, simplicity, focusing on simple messages and solutions that every Kenyan would understand, inclusivity of all stakeholders, whether in public or private sector. The objective of this advocacy initiative is outlined as below. First, it was to increase awareness and promote a sense of urgency among leaders on the need to scale up high impact interventions around cancer, HIV control, maternal and child health. Additionally, it was to sensitize and advocate for sufficient resources for HIV, as well as health programs related to mothers and children. It also wanted to mobilize the participation of men in reproductive health to inspire and promote a culture of accountability. The Beyond Zero campaign is anchored on several development blueprints. Key among these are Stay Free, Start Free, and AIDS Free by 2020, which ended. And the just concluded Kenya's elimination of mother-to-child transmission framework. Allow me to take us back to 2013, where we can appreciate the indicators that were there for mothers and children. There were women and children were dying from preventable deaths, as outlined there. Mandera had the highest maternal deaths at 2013. In terms of HIV infections, those are the figures that are shown on the slides. Two strategic frameworks have been implemented or currently being implemented. The first one ended in 2017, and we're currently implementing the 2018 to 2022. And the basic idea of these frameworks is to address the objectives that I've just outlined. Each of these frameworks have different themes, but they are all centered around mothers and children. And of course, mothers and children continue to remain at the heart of Beyond Zero. To implement the two strategic frameworks, Beyond Zero took up these key interventions, but ultimately they seek to address the increase to access to healthcare services. My intervention today is to speak about the Beyond Zero mobile clinics, whose aim was to strengthen Kenya's health infrastructure, which is devolved. They are used to provide outreach services in hard-to-reach areas and strengthen referral mechanism between primary and tertiary care levels. Within the Kenyan health system, the mobile clinic is considered as a level 2 facility, similar to dispensary. It has a master facility listing number, which allows it to receive supplies like any other facility, whether it's static or mobile. It's able to upload service data on the Kenya Health Information System. And all the mobile clinics have service register that are provided by the Ministry of Health to record client information. Each of these mobile clinics is fully kitted with a total of 52 medical equipment and items, and it has partitions that allow a child to receive vaccination, allow for a mother to receive cervical cancer screening, allow for a small section within the mobile clinic to provide diagnostic services through a laboratory. Some of the services that are provided within the mobile clinic are listed as follows: antenatal, family planning, screening, as I have mentioned, of breast and cervical cancer, HIV testing and counseling. It has an area where women can receive health education talks on diabetes, hypertension, nutrition, similar as what you see in the picture that is on your left. The different cadres for healthcare workers, as outlined in the slide, allow for prevention and treatment of services. It also assures that health education talks happen. However, the number of healthcare workers is dependent on the services to be provided when they go for their outreaches. During the deliveries of each of the mobile clinic, intensified advocacy to end stigma and encourage mothers or women of reproductive care was key. These events also allow testimonials to be shared to create awareness and provide encouragement to the public. The picture that you see on your left is one of the deliveries that happened up north in Kenya. And basically that was when Her Excellency provides the key to to the mobile clinic, to the recipient governor of the county. The First Lady started running marathons, 5 marathons and five half marathons and 1 full marathon, to raise funds to implement the 2 strategic frameworks and also create awareness for HIV treatment, adherence, HIV testing, and counseling. Each of these marathons are held on the 8th of March to coincide with the International Women's Day. Over 14 million people around the country have been reached with these advocacy messages. And these advocacy messages are very simple. For example, the public will be told it is important to breastfeed exclusively for 6 months. It is important to be tested for HIV, and if you're positive, it is good for you to adhere to your treatment. Out of, to date, over 750,000 women, children, and men have received an array of services from the mobile clinics. And as I've mentioned, they are used as outreach services by the devolved units in Kenya. So they go from one place to another providing services. Each of these mobile clinics is fully owned by the devolved government unit, and the mobile clinics receive reimbursements from the National Insurance Fund for pre- and postnatal services, meaning that they are able to get money from our social insurance fund in our country. And some of these services also include HIV testing and counseling. With regards to the impact of the mobile clinic as a result of the first strategic framework, there has been good progress. There continues to be a drop in the number of new HIV infections, especially among children. The medical safaris have been scaled up through the mobile clinics, as they are very large outreach programs that are conducted across the country and host regional events. They provide free specialized services such as screening for cervical, breast, and prostate cancer. They are able also to provide PMTCT services. They do checkups for pregnant women. They assess elderly people for eyes. The Beyond Zero campaign has hosted several of these medical safaris across the country, and they attract citizens across from different regions. Say, for example, if it is Nairobi, it will attract people from the environs of Nairobi, say that maybe it could be Machakos, Kiambu, or Kajiado. The medical safaris have served over 40,000 households in the country. So in terms of the policy changes that Beyond Zero has effected, key among them is the improvement of quality of care through the quality model for health, which is a quality improvement processes for healthcare facilities in the country. And these touch on also on HIV prevention and services. To date, 22 counties in Kenya have developed their EMTCT business plans to guide the implementation of prevention to mother-to-child transmission of HIV. These business plans are important because they allow for devolved governments to resource for PMTCT services and pursue specific implementation approaches based on their context. Additionally, through this advocacy initiative, the First Lady has been instrumental in advocating for point-of-care testing technologies, where the turnaround time for testing babies after they are born has improved drastically in the country. And now it is possible to be tested as soon as the baby is born, and the mother will be able to go home with her results. In addition to some of those gains that we've had around HIV, we've also had gains on obstetric fistula, with policy acceleration being one of the few countries in Africa that have a strategic framework on female genital fistula, in addition to having policies around guidelines for how to provide routine services. Another policy, which is also linked to HIV prevention, is a guide for eliminating cervical cancer, which has been launched by the First Lady. Kenya continues to make progress around the targets that we've set as ourselves. And as I conclude, it is my hope that similar initiatives around the world can be implemented to accelerate policy and resources for the HIV response, as well as contribute to the increased uptake of prevention and treatment services. And with this, I say thank you.
Thank you, Dr. Angela Langat, for this very interesting presentation. I am now pleased to pass the floor to Dr. Celestine Mugavi, the Head of Technical Support at the National AIDS Control Council, Kenya, who will be moderating the question and answer session. Celestine, the floor is yours.
Thank you very much, Julian, and good afternoon or good morning, depending whatever part of the world you're in. Thank you very much to our esteemed speakers and panelists for the very good presentations. Dr. Clemencia for taking us through the trials and the innovation around HIV prevention, Dr. Andrew, Professor Ngure for giving us the experience from your countries, and Dr. Angela for really showing us the importance of private PPPs, the power of the community, and most important, high-level advocacy, and really showing us innovations where we could potentially market our prevention interventions and our prevention tools. So welcome to the Q&A session. I am going to ask that you type your questions in the Q&A chat box. Please keep your questions very brief and very specific to who you want to answer. For my panelists, I shall be reading out to you the questions that so far have come in. And even as you respond, please be very brief to allow us to go through as many questions as possible. So on to the first batch of questions, and this one I'd like Dr. Clemencia to respond, just to find out what are the major challenges being faced at the introductory level of trials, at the community level. Do we have target populations that collaborate, or do we generally have resistance as we start off the trials? So Dr. Clemencia, maybe very quickly, you can take that one.
Thank you very much. Of course, the prevention studies are not without challenges. There are a lot of challenges, but what matters is to preparations. And preparations, you have to involve the community so that the communities understand and they are with you on board from the time you are starting. Even before the protocol is approved or by the regulatory, you have to go to the community and sell the idea what is coming, and they have to also assess themselves that actually we need these products. So without community, you can't do much. The communities, they live with the communities where we get the population for research. They will know which areas you have to go. They know how the people live. They know the difficulties they have, but of course, we have also the CAB, the Community Advisory Board. They are very useful in mobilizing community. So if you are researching, for example, in the ring, the first, or we had the studies which didn't go through. I mean, we are well done, but eventually efficacy wasn't approved. I mean, wasn't the answer, but we learned a lot from them. And what we learned that actually, as you move on with the researches, you have to have some to build in quality component. I mean, qualitative research, because as you move on the qualitative research, you are going to understand what people want, what are their difficulties, especially when you are having families, they would tell you, you know, you can't move at this time. So when you know the barriers from the previous studies, you can address this. And you know that partners, even if these people are high risk, they have their partners who are primary partners. And if you have any tricks to involve them, and they understand that actually, even if they know that someone with a partner is not supposed to, you know, to go to be at high risk, but they will realize that actually sometimes they are exposed to risks. So when you mobilize the men as well, if you are doing research in the younger people are going to help you to go to the areas where you can mobilize the population and get the rightful people. You can involve parents. We have in the REACH study where we had adolescents participating in the ring. The parents were very useful because we gave them education and they got to know that actually their daughters and sons are at high risk. And if they support them, they may get, they will get what they want. Of course, it is hard to believe that you can actually give in your daughter that you go and participate in the research. But if it is not their direct daughters or children, they can indirectly get to the others and convince them to be in the research and eventually get the right people.
Thank you so much, Dr. Clemencia. So thank you. So I think what you're saying, we have to keep the individual at the center of the research, and most important, the community around them. Thank you very much for clarifying that. Dr. Andrew, I have a couple of questions for you. The first one, what are the risks of discontinuing and reinitiating PrEP multiple times? Is there any chance of PrEP resistance? The second one, has there been any documented reaction or allergy to use of PrEP? And the last one, in your presentation, you mentioned addressing stigma as a strategy to optimize PrEP delivery. Could you please give some examples of community or clinic-based actions that have been rolled out to address the stigma?
Thank you, Dr. Mugambi. These are excellent questions, and thank you for asking them. So regarding PrEP, yes, you can cycle on and off PrEP, just as you can cycle on and off contraception. PrEP is given for seasons at risk, and sometimes people stop being at risk. An example is a Ugandan sex worker who hears that a US naval ship is docking at Mombasa and decides that she's going to go and do sex work for a month, and so she can take PrEP, go to Mombasa, do sex work, and then come back to Uganda and go back to her farm and just cycle out of sex work. And so she doesn't need PrEP when she's not doing sex work. So that's an example. Side effects are, of course, a concern, but they're not, I think, as serious as perhaps people think. They're mostly experienced in the first 2 weeks of PrEP, what we call startup syndrome, and there's mostly GI symptoms like nausea and abdominal discomfort and flatulence and dizziness and maybe headache. Resistance is a concern only when somebody gets HIV. And in our PrEP studies, HIV incidence has been approximately 0.5%. You cannot get resistance to PrEP when you do not have HIV. So resistance is actually mostly from treatment and not from PrEP. Dr. Mugambi, did I answer all three?
Yes, there was the one about stigma.
Oh, yes.
Most interventions were there, yes.
Stigma is a really big concern, and it's both, it's at a multi-level. It's a personal stigma, internalized stigma that somebody feels at a personal level. It's interpersonal as well as community, and there's also structural. So for example, if I'm a sex worker and I go to a clinic and the nurse hears that I'm a sex worker, she may call her friends and say, come see this sex worker who is, has an STI. So normalizing PrEP is one of the things we're doing. In my talk, I mentioned that we're looking at a new drug called TAF as PrEP. And the first thing I did when I gave it to participants during a community consultation was they said, wow, it's in a different bottle than treatment, and it's a different size of pill. This will really help us to take PrEP, because they're really concerned that when we use the same drug, exactly the same drug, they are mislabeled as having HIV. Secondly is to normalize PrEP and tell people that this is a drug that you can take to minimize your risk. And one of the things we do is give people self-test kits that they can use to test themselves, so they don't have to go to a clinic and be seen queuing at the lab for an HIV test. When you deliver PrEP through community drug distribution points or through peers, people don't have to go to an HIV clinic and be seen there. They can go for initiation and for their refill, but you can refill them in the community. So normalizing PrEP normalizing HIV prevention helps to destigmatize taking PrEP. Thank you.
Thank you very much. And as we speak about normalizing and stigmatizing, Angela, there is a question here for you. Angela, I love the medical safaris interventions. I'm interested to learn whether it's just one truck that moves across the county or rather operating at any time. How sustainable are these? But let me just add, there's a lot of questions coming in around adolescents and young people and how we can actually make it normal for them to uptake HIV prevention services. Now, based on your experience with the Beyond Zero mobile clinics and the aspect of integration, what would you respond in terms of destigmatizing HIV prevention, but also using these innovations and platforms to reach young people? Dr. Angela?
Thank you, Dr. Celestine. Regarding the integration of services for young people, the mobile clinics travel from one place to another within a devolved unit, and we could refer to them in Kenya as counties. And so they have a rotation system where they'll move from a certain ward to a certain ward. And throughout that movement, because it's an outreach that's being done by the county governments, basically they'll provide health education talks. And health education talks, there's an opportunity here that would exist for awareness around the different prevention methods that are available, similar to what Clemencia or Andrew, Dr. Andrew or Professor Kenneth have talked about. So the opportunity is there to do the integration in terms of health promotion and of course, allowing for the prevention services to happen. The medical safaris are also another instrument as an outreach instrument that move from county to county, which is a bit different from the mobile clinics. Again, there's routine, we provide PMTCT services. We also provide an array of different prevention methods that are available for people to come and interact with the services. So the opportunities exist and they are there. Then in terms of sustainability, I mentioned it earlier that what has happened is that through the reimbursement package that we received, that we have together with NHIF, the county governments have applied that they're able to receive reimbursements for the mobile clinic for services they provide for a pregnant woman. So from a sustainability perspective, that's one element for healthcare financing for the mobile clinics.
Thank you very much, Dr. Angela. Professor Ngura, I've got two good ones here for you. First one from Dr. Bienvenu from AHF. How is the adherence among sex workers and the strategies to enhance the adherence on PrEP? As many studies have found that there is consistency in taking PrEP, even ARVs, among sex workers. And the second question, how are you integrating the pivirine vaginal ring into the existing oral PrEP service outlet? Are there any challenges at country level regarding the ring introduction? And what about the successes of combining the two and efforts made so far towards the same? Professor Ngura?
Thank you, Dr. Mugambi. I appreciate those questions and they are quite interesting. I want to say, first of all, is adherence to PrEP is not only a challenge for sex workers, it's a challenge for many. And as you know, for all of us, taking a daily pill, whether it's your antibiotic for 7 days, is a real challenge for many. So there are challenges across many populations, but thankfully, it is not a challenge for everyone. And there are tools to support the adherence for those who are facing adherence challenges. For example, SMS and others that are being taken up by some projects. But more importantly, is that the HIV prevention toolbox is having more tools that some of them, like now the pivirine vaginal ring, will not require daily adherence. So for those with challenges of daily adherence, whether they're in sex work or not in sex work, then they could be able to have an additional tool. And then as the other tools that were mentioned earlier by Dr. Clemencia and Dr. Mujugira, the tools like the injectable cabotegravir will come and sort out some of these issues for those with adherence challenges. So it's many populations are facing it, and it's actually adherence is known as the Achilles heel of PrEP. So, and then the other question was on the dapivirine ring. Currently, the ground is being prepared for the dapivirine ring rollout in Kenya. It's not currently being rolled out, but I do not anticipate to find it as a challenge. As I said, oral PrEP joins the prevention toolbox. So even when the dapivirine ring comes on board, it's going to be an additional tool in the HIV prevention toolbox. I foresee, and I hope that's what is going to happen in the next few years, is that the HIV prevention arena is going to mirror the contraceptive arena, where you have injectables, orals, implants, and people make choices at different times and at different times of their life cycle so that they can use what works for them at that time. And just also to echo a comment that Dr. Mujugira mentioned, that risk is seasonal also. So some of these tools are going to be used during those seasons of risk, depending on somebody's individual circumstances. So the more the merrier. Over.
Thank you very much, Professor Ngure. Angela, I think one last one for you. You can take a stab at this one. Why is it hard for the point of care for early infant diagnosis in Uganda when other countries are using it? I don't know if you should be the one responding or Dr. Andrew.
I think it's Dr. Andrew.
Dr. Andrew, would you want to take that one? Why is it the point of care difficult in Uganda while other countries are using it?
Thank you for that question. I presume you're referring to point of care testing for early infant diagnosis using red blood spots. So this is done at health centers across the country and centrally tested in Kampala. You are correct. We as a country are not doing well. I think the last data I saw only 56% of results were returned in time. We need to do a better job of linking, of testing babies. Not all women deliver in health facilities, many deliver at home. Sometimes they travel. The clinic where they get the antenatal is not the clinic where they deliver. And what we are now doing in research is to now start doing point of care viral load testing, where you can test a mother at delivery and test the baby soon after birth and give them results same day. And that may improve our outcomes in getting results back to the mothers and the babies in a good time. Thank you for the question.
Thank you very much. There's a question here which I think is a purely clinical one, but I'll read it out. A cisgender female sex worker on 3-monthly methylprogesterone IM, can they be initiated on TDF-FTC as PrEP, or should they get a different combination? This is from Dr. Martin A. Khan from India. So Professor Ngura, would you like to take that one?
I could take it, but I think the best person placed to respond to that would be Dr. Mujugira, but I could take it if he wants.
Okay, Dr. Mujugira, you have been nominated.
Yes, thank you. Clemence is obstetrician here, but yes, there are no contraindications as far as I know between oral PrEP and contraception. I know that some antiretrovirals reduce, like efavirenz, reduce concentrations of contraceptives, but not oral PrEP. So as far as I know, there are no contraindications.
Okay, Dr. Clemencia, would you like to add a comment to that?
Yeah, research has been done where they found that actually, did you say combination of injectable?
Yes, they're on IM, just let me get the question, IM methylprogesterone.
To be contraindicated?
So they're asking, can they be given the 3-monthly IM methylprogesterone with TDF-FTC as PrEP, or is there a contraindication?
No. There is no contraindication. I think they can be given.
They can be given.
Yeah.
Okay, thank you very much. Dr. Andrew, maybe just the last one for you. From the Uganda perspective, adolescents and young people, what have you done to put in place strategies for them to uptake HIV prevention interventions as we wrap up?
Thank you very much. Actually, just in following up the last question, yes, we're actually doing a study where we're giving young women both Depo-Provera and PrEP. In terms of young people, so a number of interventions have been done to increase PrEP uptake, including the DREAMS initiative funded by the United States government that has been rolled out across sub-Saharan Africa. We are doing a number of studies where we are giving PrEP to young women. As you know, they have high HIV incidence. and normalizing that. And one of the studies we're doing is actually bringing the young women's sexual partners into clinic and testing them for STIs. So they come in to test them for STIs, we assess the HIV risk, and we give them PrEP. One of the things that is the problem is that we stigmatize sex as a society, and that issues around sex are hush and taboo. And until we can normalize talking about sex, we will continue to stigmatize PrEP and HIV. Thank you very much for those questions, and thank you, moderator.
Thank you very much to my esteemed panel for the excellent answers and to the many good questions that we have gotten. I hope we've been able to address everything. Remember, the overarching message is HIV prevention interventions. We must have a toolbox. No one size fits all. We have to give people choices that they can make that suits their lifestyle. Thank you very much. And over to you, Julian.
Wow, thank you very much, Dr. Celestian Mugambi, for moderating this session. And thank you once again to all our speakers for your very informative and interesting presentations on innovative HIV prevention methods. Would like to also thank all participants, and we hope that this session has been helpful and interesting to you. We hope that the information shared and discussed during this session will help you reflect on a personal and professional level and help you understand the importance of engaging adolescents and youth as primary actors in the HIV response in Uganda and East Africa. We would also like to thank all participants who sent their questions during the discussions. And we also encourage you to share the recordings with your colleagues who were not able to participate live. This will be available as soon as possible on the IAS Education virtual platform, free of charge, and they can join the platform anytime to watch the replays, which will be available next week. Thank you to our speakers for your contribution and the participants in this session, especially during the special and very busy time of the year. Please do not forget to participate in the survey, which will be shared tomorrow at the end of the symposium for a chance to win a free one-year IAS membership. Thank you all and take care of yourselves. We hope to see you tomorrow at 11 a.m. East African time for our third and final session of the symposium. The session will focus on HIV, adolescents and youth, the next critical actions. Please connect using the link for session 3, available on the homepage at the virtual platform, just as you have connected for this session. We will see you again tomorrow. Thank you. Thank you again.